because I know some of you have to scoot off after this session. So good morning, everyone, and welcome to our weekly CMR conference series hosted at VCU. Very pleased to be having a focused congenital session this morning with three speakers. Dr. Sangeeta Shah is going to go first, VCU, and then we're joined by Dr. Uyen Truong from Children's National, and then Dr. Shaimaa Fadl also from VCU, and they've all got some cases on a theme. Just a reminder to everyone, if we could just throw up the CME slide for a second, just so everybody can claim credit. These sessions are CME and MOC accredited, including for pediatrics MOC. So don't forget to text the code on the screen to the number provided. And we'll go ahead and turn it over to Dr. Shah first. Thanks everyone for doing this. Looking forward to it.
Thank you. Well, super excited to be here and presenting with two other people that I value greatly in this field. So I'm just going to go through a little bit of basics for ASDs as we go through case base. So secundum ASDs, the most common one, 80% of the time, it occurs in the fossa ovalis. It can be one defect. What I want you to remember, there's something called a Swiss cheese ASD. So just because you find one hole doesn't mean that there's not another hole. So it's important to detect the whole atrial septum and make sure there's not just one hole. Imaging wise, I think you can do all four modalities. I think each one has its benefits. You know, transthoracic echo you end up doing for screening. TEE helps you to see multiple holes, multiple sizing of the holes. Cardiac MRI helps for, as well as CT, helps not only for the sizes, but also quantification of flow. You want to look for associated anomalies such as anomalous pulmonary veins, and usually has good options for percutaneous closure. Sinus venosum defects occur in 5 to 6% of cases, and it basically can occur at the mouth of the vena cava. So it can occur at the SVC mouth or at the IVC mouth. The one at the IVC mouth is very rare, often associated with anomalous pulmonary veins. And imaging-wise, MRI, CT, and TE are instrumental. Transthoracic echo can be difficult, and what I want to highlight to fellows is sometimes I've seen people have a bubble study, and the bubble study is negative. The right heart is enlarged, and we miss the sinus venosum defect because the bubbles go preferentially to the right heart and don't go across that angle, that steep angle to the left atrium. Surgery is generally what people do. However, there has been percutaneous covered stent options, and we have been doing that here at VCU. Primum ASD is located at the bottom of the fossa ovalis above the AV valve. It commonly involves malformation of the AV valves, the right-sided and left-sided AV valves with regurgitation. And generally, transthoracic echo, TE, and MRI are diagnostic, and I'll tell you that I had trouble finding an MRI because we generally make the diagnosis by transthoracic or TE and then proceed to surgery. And this occurs in about 15% of individuals with ASD. Coronary sinus defect is less than 1%. It is very interesting. The LSVC comes behind your left atrium. There's a wall between the coronary sinus and the left atrium, and the coronary sinus drains into your right atrium. What can happen is you can have absence of the wall between the coronary sinus and the left atrium. Usually when it's large, it's diagnosed in childhood, but we do find in adults little pin-sized holes of which there is what we call a sinus venosum defect. Transthoracic echo with bubble study, a bubble study in the left arm is instrumental, and you'll see bubbles coming in straight into the left atrium in that case, MRI and CT. Generally, this is surgical repair. However, if there's small holes, percutaneous is an option. So I'm going to go into my first case, and this is a recent case. She's 19 years old. She's been feeling well until she got COVID in October 2022. And then presented with RSV and respiratory failure in June 2023, and that's when we met her. She had a history of asthma, iron deficiency anemia, And over time, we diagnosed her with a carrier of alpha thalassemia, which does not pertain to this whole thing. It was just in our thorough workup. Oh, hold on, guys. What happened to my order of my imaging? I'm a little off. Give me a second. I'll move it to. Oh, there's my closed captions are back. There we go. So when we're looking for MRI, we want to look at location. The size is important, and whether there's rims. And what's nice about this is 4-chamber stack SSP, and you can see that it's a pretty sizable ASD. And when I looked at this measures about 31 millimeters. It does look like it may have rims, and so you're optimistic. You have tricuspid regurgitation. You see that the right heart is enlarged. In the short axis stack, it's very nice to see. Here's the left atrium superiorly, here's the right atrium, and you can see a distinct wall there, which helps for the diagnosis that it's not a sinus venosum defect. Here you see a large hole, and you continue in the stacks to see it in short axis. So this is important. And what I'm going to show in one more image is that the rims here start to look deficient. I thought this image was really good to show the anterior rim. So here's the aortic valve, and you can see that the interventionalist would not have something to be able to lodge in right here. So between the size of it and deficient rims, she was not a percutaneous option for that. We also allow QPQS and ventricular size and function. And when you look here, her RV is 125 cc's per meter squared in end diastole and 68 in end systole, which is close to double of what the LV is, which is a good parameter for us that is a definite enlargement on her part. QPQS is 1.4 to 1, and you probably wonder, why is it so little? It's because now she's developing bidirectional flow. Shunt fractions by QPQS, here's your flow of your pulmonary. It was 85 cc's. Your aorta is 60 cc's. Shunt fraction is 1.4 to 1. So sometimes it's nice to correlate those and see where you are. You want to evaluate for anomalous pulmonary veins. So I have this angio picture that I grabbed, but she has, here's your IVC coming up. Here's your right lower, right upper, your left just coursed by. And so no anomalous pulmonary veins to worry about in her. So she has, by MRI, a large secundum ASD, not amendable to percutaneous intervention that we can tell by MRI by itself. She has no anomalous pulmonary veins. She has QPQS of 1.4 to 1, increased RV volumes with an RVEF of 45%, and normal LV volumes with an LVEF of 57. She did have TR that I showed you. Her MR was there, but not as visible. On echocardiography, which you need, her RV pressures were very much increased. And I'm going to show you the course of her cath and time that she was with us. And basically, I want you to pay attention to the PVR and to the PA pressures. And what you'll see, and this is June, and this is March of 2024. And her PA pressures are basically in the 50s. We dropped them as low as in the 40s. Right before surgery, her systolics were in the 50s. Her PVR, we were able to bring down from 17 slowly. So initially we had a PVR of 17. We gave her nitric oxide. It did not change. Started her on pulmonary hypertension medicines. Her PVR dropped to 5.6. With nitric oxide, she got down to 2.4. And then right before surgery on maximum medical therapy for pulmonary hypertension, we got her down to 3.6. So ASD repairs, and I put this in the right upper quadrant, it's class indications just for people to visualize it. So if you're at 3 Woodsley units, which is your PVR, less than 3, go ahead and close it. If it's 3 to 5, if it's a class 2A, which is there's a benefit greater than the risk. When you get to class 2B and your PVR is greater than 5, which decreases with pulmonary hypertension medicines less than 5, then you should close it with a fenestration. And the risk and benefit is unclear, and you have to be at a really strong center to pull this off. So she fits actually class 2B. And if it's greater than 5 Woods units, please be careful. So she underwent surgical repair on the 4th of this month. And I'm going to show you her tricuspid regurgitation gradient came down to 36, which is impressive. I put this 4-chamber view to say, hey, her RV is doing its thing, it's contracting. And the surgeon left a fenestration in is where you see this positive bubble study. So initially post-op, we had a lot of trouble with hypoxemia because she had pleural effusions and things, which has also improved. As her pleural effusions have improved, her hypoxemia has. So she's probably shunting a little less. But this is to protect the right ventricle, basically, that you do this for. That's all I have. And I'll let Lynn go.
All right, I'm going to hand it off to Shaimaa because I'm having technical difficulties. Shaimaa, if you don't mind, sorry to put you on the spot.
Share my screen. There we go. Good morning, everyone. I'm sharing few cases about the sinus venosus defects. The first case, she's a 45-year-old woman presented with symptoms of deconditioning and fatigue in outside facility. She was catheterized in November 2020 and revealed concerns for pulmonary hypertension. After that, she was referred to our center for further evaluation and detection of underlying etiology of pulmonary hypertension. On family history, the patient had prior history of myocardial infarction in maternal grandfather and maternal uncle. On physical exam, the patient had systolic murmur. Starting with the cardiac MRI images, this is multiple cine-state free precession images. Starting superiorly, you can see that there is an anomalous pulmonary vein draining into the SVC. Going more inferiorly, there is a deficiency of the posterior wall of the SVC near its insertion site to the right atrium. And going more inferiorly, this deficient wall act as an interatrial communication between the left atrium and right atrium here. At the same time, there is another vein inserting to that region where there is interatrial communication. And going more inferiorly, you can see the enlargement and dilation of the right atrium and right ventricle. And there is a tricuspid valvular regurgitation, probably because of the annular dilation of the annulus of the tricuspid valve. This is a sagittal view of the SVC, and it is, you can notice the deficient posterior wall near its insertion site to the right atrium. This is the IVC communicating with the right atrium, and this is the SVC, was supposed to be just communicating with the right atrium, but this defect along the posterior inferior wall has resulted into interatrial communication between the left atrium, this is a portion of the left atrium, and right atrium. This is subsequently will result into left to right shunt. This is a coronal view and showing the anomalous venous drainage from the right upper lobe inserting into the lower aspect of the SVC. And this is the post-contrast T1 vibe. It is helpful in showing scrolling inferiorly, you will start to see here at that level the significant dilation of the pulmonary arteries, particularly at the main, when you compare the main pulmonary artery to the ascending aorta. At the same level, you can see that there is a venous, anomalous venous drainage from the right lung to the SVC. Going more inferiorly, this is the interatrial communication site, and going more inferiorly, you can appreciate that anomalous vein coming from the right middle lobe and inserting into the location of that interatrial communication. This is the dilation of the right side of the heart. The diagnosis was established: superior sinus venosus defect associated with partial anomalous pulmonary venous return from the right upper and right middle lobes. The QPQS was 2.7 and reaching 3 to 1. And the patient has underwent repair of that defect with pericardial patch. They established a pericardial patch to close that defect and redirect the pulmonary veins toward the right side. Sinus venosus defect, just a quick overview. It's when the cava, the superior vena cava or inferior vena cava overrides the interatrial septum because of a deficiency of the posterior wall. And it's best imaged in axial or transverse planes and sagittal planes as well. The superior defect, which is from the lower deficiency of the wall of the SVC, is more common than the inferior defect related to the IVC. Flow images can be helpful, sometimes showing that flow and of the interatrial communication with the flow coming between the both atria. And it's, as Dr. Shah was mentioning, it's 5 to 10%. It's located at the mouth of an overriding SVC or IVC. Most of the time it's associated with partial anomalous venous return, and mostly it's from the right lung. Usually when it is as a superior venous defect, it's right upper and right middle lobe venous drainage. And when it is inferior defect, it's usually the partial anomalous pulmonary venous return is from the lower lobe, right lower lobe. Yeah, this is a repeated slide. So the whole goal from the management is to adequate closure of that defect, so you can redirect the SVC or IVC to the right atrium, and to allow unobstructed pulmonary venous drainage from the right lung to the left atrium. Usually it's managed surgically, but there is a rising role for the transcatheter management. One of the surgical procedures is Warden procedure, where you are aiming, the surgeons are aiming into directing the anomalous venous return to the left atrium and reconnecting the SVC or the IVC to the right atrial appendage. So it allows the oxygenated blood to go to the left side of the heart and the deoxygenated blood to go to the right side of the heart. The rising role of the covered stent, it's a transcutaneous approach, minimally invasive, and the placement of a covered stent that can cover that interatrial communication or that deficiency of the wall of the lower SVC or is rising. And at the same time, it allows redirection of the anomalous venous return toward the left atrium. This is this is my second case with a different management. This is a 59-year-old female with sinus venosus defect. You see here the SVC overriding the left and right atrium, and this is the defect of the lower posterior SVC. This is images from, this is a 3D volume rendered images from a CT angio of the same patient, and there was multiple anomalous pulmonary venous drainage toward the SVC, at least 2 lower and one at higher level. And this is the interatrial communication. And scrolling through the patient has underwent that stent placement. They placed 2 stents, covered and uncovered, overlapping. The covered stent were aimed to if we stopped here, it's aimed to close that interatrial communication and redirect the SVC. You see here, it's bright contrast material flowing from the SVC to the right atrium to go all the way to the right atrium and right side of the heart. And at the same time, the uncovered stent is placed superiorly, and it allows that the venous return from the right lung, like here, that vein, should be going to the left atrium, or allow some drainage to the SVC as well. Like it can be redirected to the left atrium, but if there is any small residual venous drainage to the right atrium, it can be sacrificed, and some patients sacrifice that, they keep it as it is. And this is the sagittal view showing the stent placement, and this is the interatrial septum, left atrium, right atrium, and this is the stent placement to cover that defect in interatrial communication. This is the third patient, 75-year-old African-American woman, was referred for evaluation with history of chronic AFib and repaired as sinus venosus defect at the age of 23. And the steady state sinus free precession images shows significant left atrial dilation and also some right atrial dilation. There is significant mitral valvular regurgitation as well. And this was, the patient was in AFib, and this is the steady state free precession through the axial images. And this is the left atrium, right atrium. And I have a question. What do the MR findings indicate? Do you think this is normal post-surgical repair? Do you think this is a normal cavo-atrial connection? Excellent. So yes, this is the IVC connected to the left atrium. This is the IVC should be directed to the right atrium. And this is a post-surgical appearance. In the attempt of repairing of that sinus venosus defect, most likely inferior sinus venosus defect, the direction, redirected the IVC to the left atrium instead of the right atrium, which is a reported complications that can happen post-surgical. And this is another view for the images of the IVC communicating with the left atrium here. Other axial images showing the IVC going directly to the left atrium. Probably the patch repair was meant to be, should be going to the posterior wall, and instead, so it can redirect the IVC toward the right atrium, but that patch was redirecting the IVC to the left atrium. And with subsequent huge left atrial dilation and subsequently AFib, chronic AFib. And this is the post-contrast T1 vibe. I find it's really helpful in showing the anatomy. And this is the IVC connecting to the left atrium, huge enlargement of the left atrium and left atrial appendage. There is no residual like interatrial septal defect in the previous images. I think there was a reported PFO, but otherwise there was no significant defect of that patch. And the patient, they took the patient to surgery. She was, they did redirection of the IVC now to the right atrium, to the correct direction, and they did a mitral valve repair, and they are doing follow-up for this patient. So they did that correction like 10 years ago, and the patient is under follow-up for the atrial. They did also some atrial wall reconstruction, but otherwise, the patient is just under follow-up and surveillance after that surgery. Thank you very much. I will stop sharing and that when.
Yeah. Thank you, Shaimaa. I wanted to make a comment about the case that you just presented. Unfortunately, it's not uncommon to see that type of reconstruction of the defect leading to a connection of the IVC to the left atrium, because when you look at the echo and when you look at the transesophageal echo, people often mistake the eustachian valve as the atrial septum, and they will connect the anterior eustachian valve to the more superior atrial septum, and that's why this exact scenario occurs. But it's unfortunately not that uncommon. So when you're doing TE to help guide surgery, just be aware that you need to clearly define your atrial septum versus your eustachian valve.
That's very helpful. Thank you.
Yeah, of course. Okay, so my job was to talk about the primum defect. We did see a 19-year-old recently who has a history of autism and congenital hypothyroidism. She presented to the emergency room because of complications of having not taken her levothyroxine for a few days. But during that visit, she was found to have a new murmur. Clinically, she has some fatigue, but it's usually related to her thyroid. She otherwise isn't play sports, so it's hard to know exactly what her activity levels are. She's otherwise asymptomatic from a cardiovascular standpoint. She's growing, developing normally. On exam, she does have a significant murmur. Okay, so on EKG, she has normal sinus rhythm, but a left axis deviation. So when you guys see a left axis deviation in adults, one of your differential should be some form of AV septal defects. Any types of AV septal defects will have this finding on their EKG. Okay, so left axis deviation again is a -30 to -90 on EKG. This is her echo. And when you look at the peristernal long axis view, what strikes you is that there is some sort of connection between the anterior leaflet of the left AV valve to the septum. And this is unusual because the left ventricle is classically described as septophobic, meaning that the AV valve does not like to connect to the septum. When you have AV septal defect, this is one of the few times that you will see some sort of connection between the AV valve and the septum. When you put color on, you realize very quickly that there is regurgitation through that left AV valve. Peristernal short axis view, you can see again that there's something unusual about the anterior leaflet of that left AV valve. It looks as if it doesn't have a complete formation of the leaflet, and that there's kind of like a V pointed towards the septum. This is what we call a cleft AV valve. Okay. So similar to what Sangeeta had mentioned about for the primum defect, if you image in the apical view and your septum is right parallel to your ultrasound beam, you are not going to be able to see the atrial septum. But if you tilt your apical picture a little bit so that you have some angulation between your beam of interrogation and your atrial septum, you may be able to bring out the septal defects. So in this case, you can see that this is the crux of the heart, of course, and there's a large primum defect right above the crux. This also gives you a nice picture of the inlet region of the VSD, which forms the ventricular component of the AV septal defect. And we did not appreciate any ventricular level shunting in this patient. Okay. So the primum defect falls under the spectrum of atrial ventricular septal defects. These represent about 4 to 7% of all types of congenital heart disease. What is a common denominator in these defects is that there is an underdevelopment of the endocardial region of the heart, meaning right at the crux of the heart. So whether you have just a atrial portion, just a ventricular portion, or both, it always involved the endocardial cushion. The age of presentation depends on the size of the defect, the level of the intracardiac shunt, and as well as the associated lesions. Remember that a lot of these patients will come to you with an associated syndrome. You cannot talk about AV septal defect without mentioning trisomy 21. The classification of AV septal defect is such that you can have a partial AV septal defect, which is what we're going to talk about today, in which you have just an atrial component or just a ventricular component. And then you have the intermediate where you have a small VSD component, and then the complete in which you have a large atrial component as well as a large ventricular component. So when you talk about the partial AV septal defect, in this case, we're talking about the atrial level communication. You usually have a large primum ASD. You usually have two fully separated AV valves, and you have some sort of dysplasia or maldevelopment of the left AV valve. And people who take care of congenital heart disease were a bit draconian about the way we talk about the AV valve in AV septal defect, and that we no longer call it a tricuspid valve and a mitral valve. Instead, we call it a right AV valve versus a left AV valve. So forgive me if I use a lot of terminology to describe the mitral valve. But to understand the associated lesions in AV septal defects, you have to understand what is malformed in the crux of the heart. So in the normal patient, you have separate annuli for the tricuspid valve and the mitral valve, and separate leaflets as well. And the aortic valve kind of nestles in between the two AV valves. In AV septal defect, what happens is now instead of having two separate annuli, you have a common annuli. And if you have a complete AV septal defect, then you have one common AV valve. If you have partial, then you have two separate AV valve, but still a common annuli. The problem with this common annuli is that the aortic valve no longer is nestled in between the two annuli of the AV valves, and instead it's sprung forward. And this becomes a problem because when it springs forward, you have unusual geometry of the left ventricular outflow tract. So that if you look at the normal left ventricular outflow tract, the distance from the apex to the left ventricular outflow tract compared to the distance of the apex to the posterior portion of the mitral valve is about the same. But in AV septal defect, because of that sprung aortic valve, the outlet is now longer. And it causes what we call a gooseneck deformity of the left ventricular outflow tract. So when you look at echoes in these patients, they have unusual and kind of curved left ventricular outflow tract. This becomes important because A, it can help you with diagnosis, and B, this is a setup for left ventricular outflow tract obstruction, which is common in any form of AV septal defect. And the reason why, you can see that the LVOT is elongated, it's narrowed, and similar to what we saw in the echo, there's AV valve tissue that is moving in and out of it. And so it's a setup for a development of, for example, subaortic membranes. Okay, so going back to our 19-year-old patient who presents to the ED, we do send her for MRI to clarify some of the details of the heart. And just looking at her four-chamber view, you can appreciate that she does have a very large primum ASD. Again, the crux of the heart is right where you see the ventricular septum and the atrial septum come together, and you can clearly see the two AV valves. Again, you can see that there's some billowing of the inlet VSD as if there's tissue in there, but there's no evidence of a ventricular level shunt. There is obvious right ventricular dilation and right atrial enlargement. And this becomes important because, so this patient measures severely dilated right ventricle with a QPQS shunt of 3 to 1. And that's important to know because These patients are at risk for developing pulmonary hypertension, and you want to understand if their degree of pulmonary hypertension is amenable to surgery, similar to what Sangeeta had mentioned. So if they have high pulmonary vascular resistance, they're not going to have a high QPQS, because a high resistance is going to prevent more left to right shunting. So if you see a large defect, but the RV is relatively normal size, be very careful that that patient may have pulmonary hypertension. This is a peristernal short axis view, again, to look at the AV valve anatomy. And you can see that there are two distinct AV valves, but that there is a cleft in the left AV valve, meaning that instead of forming a nice anterior leaflet of the mitral valve, it points towards the septum. You can see it there. Okay. This is a magnitude image of our 4D flow imaging that we use a lot for congenital heart disease. And it helps us understand the relationship of all the anatomy to one another. And as we scroll through, we can see very clearly the anatomy of the AV valve, as well as take a look at the left ventricular outflow tract and see that indeed there is attachment of the anterior leaflet of the left AV valve to the septum. Scrolling through that series, you can see if there's other associated anomalies. So primum ASDs may not just present with primum ASDs, they may present with secundums and PFOs as well. They also are at risk for developing aortic stenosis, pulmonary stenosis, as well as coarctation. And it's not unusual for them to have other forms of inlet, other forms of ventricular septal defects as well. So with this approach, you can see the other cardiac lesions and make sure that you're not dealing with something more complicated than just a primum ASD. So when we put color onto these patients, it's easy to see the left to right shunt across a primum ASD and no interventricular shunting at the inlet VSD. You can see if there's any dephasing that may occur with stenosis of the AV valves, or if there's any AV valve regurgitation, all of which are important to understand before you send these patients into surgery and to counsel them about post-operative complications. So again, this is a sweep using 4D flow through the anatomy. You can see at the beginning of the sweep how dilated the IVC is, and how dilated the right ventricle is, and see that there's no significant regurgitation through either AV valve, and obviously no stenosis and no coarctation. Okay, so I'm just going to give a little bit of natural history on the defect and then talk about some of the surgical outcomes. So this is an old study that came out in 1960 from Sick Children's, where she describes patients who are unrepaired. And you see that death can occur across the lifespan in early infancy as well as into later adulthood. When she looks at the complications of unrepaired primum defects, she breaks them down into those who are under 30 and then those who are over 30. And in those that are over 30, the primary complication is the presence of some sort of atrial arrhythmia. And those who are younger, the complications are more related to the degree of the left AV valve regurgitation. When she broke it down into just the arrhythmia, you can see that atrial fib and complete heart blocks are the primary problems in these patients. This is a paper that came out in the 2015 or so, the Mayo experience repairing partial AV septal defects in adults. So all these patients had their surgeries done after the age of 18 years. And this is a diagram of how they approach it. So again, the cleft AV valve, this is what a cleft looks like. and they would close this up to address the regurgitation and try to expand the annulus, and then put a patch into the primum region. You can see that the outcomes are pretty good. Their survival was 83% at 15 years, and obviously higher than that 5 years out. This came out recently in JACC, also describes the Mayo experience. And they looked at patients, all comers who had repair of AV septal defects, so not just the patients who had repaired in adulthood. And they found again that arrhythmias is the primary morbidity. And of course, the older the patient, the more the incidence of both atrial, all comers of atrial arrhythmias and AFib in particular. And unfortunately, a lot of these patients do go on to require reoperation. And these reoperations are going to involve some sort of left ventricular outflow tract or AV valve regurgitation or stenosis. This is their Kaplan-Meier curve looking at survival, and survival was associated with the presence of AFib, as well as their RV systolic pressures, the presence of pulmonary hypertension, and was not actually related to the degree of AV valve regurgitation. So I'm just going to put this in to remind everyone that there is an appropriate use criteria that came out in 2020 that kind of guides you along as to what type of imaging modality, when to use it, how often to use it to follow patients who are unrepaired, and then when they are repaired. In the partial AV canals, you generally can follow them with echo, especially if they present in childhood, of course. But once again, to the adult age, depending on their windows and their body habitus, you may have to use advanced imaging to really understand what's going on. And that's all I have, Sangeeta.
Can I ask a quick question?
Yes, please. Oh, yeah.
Hey, for you, Uyen, a great talk, all three of you all. Really interesting. I just love this stuff. And your slide about the long-term outcomes was interesting for the ostium primum or AV, partial AV canal defects. And the frequency of atrial fibrillation, I think, approached 50%. Was that right? 50 or 60%, something like that. And as they, as one aged past 40, it became increasingly common. I just wonder, would it be crazy to consider ligating or resecting the atrial appendage at the time of repair if they're going to have this problem 30 years later?
That is interesting. We don't generally do that, but that is interesting. And yes, in that paper, they do say that the frequency of atrial arrhythmia was higher than in patients with other known types of RV disease, such as TET. So that certainly is an interesting point to consider. But we don't do that generally.
And I appreciate the explanation. Sorry to interrupt.
No, it's okay. I think that's a great question. We actually just had a 39-year-old with a primum ASD that presented Down syndrome that we closed, and before discussion, it was, should we take out the appendage or not? This was done like 2 weeks ago. And the decision was not to by the general, but I think it's because typically we don't do that because it's typical. It's not that it's not a great idea. And but I think it's very reasonable, especially if they're 39 or if they're older already, and he's already 40 and he's likely to, develop atrial arrhythmias considering he was uncorrected for that long.
Echo Dr. Griswold. Thank you, all three of you, for giving this really wonderful overview and presenting all these cases. I had a question for Dr. Shah or anybody, but in your case, you mentioned that your patient had an pulmonary hypertension with an elevated pulmonary vascular resistance, but was then responsive to medications. In general, once the lesion is corrected, I guess in this case with the fenestration, How much reverse remodeling do you expect in the pulmonary vasculature, and do they tend to graduate off of these medications? Do they ever reach a point where maybe it can be completely closed?
So I think I don't know that she'll come off of all the medications. I think she may not be on 3 agents at some point. There's I looked it up because about 12%, so let's say 15% of ASDs end up with pulmonary hypertension. Please, Shaimaa or Uyen, correct me if I'm wrong. It's rare that they end up. We had the 40-year-old with the primum ASD all his life and doesn't have pulmonary hypertension. So I think there's something in these individuals' lungs, these 12% that develop pulmonary hypertension, that's not normal in the beginning, or they were going to be predisposed to pulmonary hypertension. So I don't think she's going to come off of her medicine. I think she'll be on something long-term and need a pulmonary hypertension doctor. As for the fenestration, we do hope to close it. In the future, I think we're going to probably wait 6 months to a year, depending on her saturations and how she's doing. But we will want to close that, and that was the pretense. And what's nice about the fenestration is that the cath lab can balloon occlude it, and we can watch what happens to the pressures, we can watch what happens to the cardiac output, and then decide to close it at that moment.
Great, thank you. Any other questions for our presenters? All right, well, if not, we'll go ahead and close the session a little bit early. Just a plug for next week, we've got another case sharing day. So if anybody has any interesting cases, please reach out to myself or Shannon, and hope to see them. All right, thanks again, everybody.
Thank you.
Thank you.
Thank all 3 of you. Thanks, Corey.